Assalamualaikum. My name is Zaira Ahmed with roll number BP1650263. I'm a student of 4th block morning with group number 25 of Pharmacy Practice 2. My major topic is chronic obstructive pulmonary disease, COPD, and I have assigned with a subtopic also known as severe COPD stage 3. Starting with the introduction, COPD, which is also known as chronic obstructive pulmonary disease, is a group of progressive lung disease that causes airflow obstruction in lungs. The most common of these diseases are emphysema and chronic bronchitis. Many people with COPD have both of them. Emphysema slowly destroys airbags in your lungs, which interferes with outward airflow. While in bronchitis, there is inflammation and narrowing of the bronchial tubes, which allow mucus to build up. If we let the COPD patient untreated, it can lead to faster progression of disease, heart problems, and other respiratory infections. On another slide, we have two images that clearly shows the difference between healthy and COPD patients' lungs. In COPD patient, their bronchioles get narrowed and blocked with mucus. Also, their alveoli become disrupted. Now we have few causes and symptoms of COPD. Starting with causes, the patient with age more than 40 years have higher risk of COPD. The main causes can be smoking. Smoking can be of any type. Cigar smoking, tobacco smoking, candy smokers. And people with allergy like asthma are very prone to COPD. Other than this, there are conditions like more exposure to chemical and fumes, genetic disposition, and another deficiency of protein, that is alpha-1 antitrypsin, can lead to COPD. In symptoms, we have many symptoms, but in early stage, there is a shortness of breath, especially after heavy exercise, a mild but recurrent cough. Then the symptoms get worse as the stage progresses. It can lead to chest tightness, chronic cough, swelling of the feet or legs, weight loss, fatigue, etc. Now, discussing pathophysiology of COPD. For example, if a patient is smoker, so the smoking causes clustering of alveolar macrophages that release an enzyme known as proteolytic enzyme. Another enzyme is released by leukocytes. These two enzymes are responsible for destruction of lung tissues. But in normal physiology, there's another enzyme, alpha-1 antitrypsin, which is required for protection. But in pathophysiology, it is inactivated by smoke oxidant, so the tissue damages continues. Subsequently, the wall of airways become weak and collapse on expiration. The intra-alveolar pressure increases, leading to breakage of alveolar septa. Now we have four major stages of COPD. Stage 1, also known as mild COPD. In this stage, their airflow is somewhat limited, but not that much noticeable. There may be a cough with mucus, but mostly this stage get unnoticeable. Then we exceed with stage number 2, moderate stage, in which the airflow is worse, often shortness of breath after doing something heavy like exercises. So this is the point where most of the people notice that they have some issue related to lungs and they may get help from a doctor. In stage 3, also known as severe COPD, there is airflow and shortness of breath are very worse. So normal exercise is not even possible. Symptoms get flare up frequently. So this condition is also known as exacerbation. Then we have stage 4, very severe case, in which airflow is very, very much limited. Flares are more regular and intense, and the quality of life is so poor. Now, heading towards diagnosis. The diagnosis can be based on symptoms, physical examination, and other diagnostic stress results. We have already discussed the symptoms. So in physical examination, a doctor will put a stethoscope on your lungs and listen to the voice, that is wheezing noise of your lung. Another method is spirometry. In this test, patient will take a deep breath and then blow into a tube connected to the spirometer. Other than this, we have image testings like chest X-ray or CT scan that can provide a detailed look at your lungs, blood vessels, and heart. Another test, also known as arterial blood gas test, involves taking a blood sample from an artery to measure your blood oxygen saturation, carbon dioxide, and other gas saturation, which will give a brief idea about COPD condition. Now we have a case study of a patient aged 66 years with diabetes mellitus and prospect stage 3 COPD. He has increased productive cough following a cold. He has been hospitalized since 6 weeks with commonly acquired pneumonia. He is former smoker. Current medication include formoterol, theophylline, albuterol. He has increased dyspnea and chest tightness. On examination, he is no acute distress and vital signs are stable. There is increased wheezing on chest examination and the rest of the examination is unchanged. Room air plus oximetry is 90% and the CXR in the office shows no inflates. How should this patient be treated? So another case of the same case, another condition of the same case is if we treat the above condition with oral ciprofloxacin 750 milligram BID. So he demonstrated a decrease in sputum volume and prevalence with decreased dyspnea after 3 days of therapy. However, 5 days later, he's feeling palpitations and has become nausea. So what laboratory values should be checked? And the subtype of this condition is if a theophylline serum is checked and the concentration is measured and it is recorded as 21 mcg ml, what action should we take? We will discuss 3 of the case studies simultaneously. Now, starting with SOAP notes, subject. We have a patient of 66 years. He has a history of former smoker, diabetic patient, hospitalization since 6 weeks with pneumonia. His chief complaints are increase in dyspnea and chest tightness, increase in wheezing. His current medication is formoterol, inhalation powder, 12 mcg twice, daily BID, albuterol, MDI 2 puffs every 4 hours, PRN, and theophylline 200 milligram BID. Then in later condition, we also use ciprofloxacin, which we will discuss later. So in object, we has let the patient check their room air plus oximetry, which is 90%. His CXR shows no inflates. Now we will assess according to his history, his subject and object. The patient has productive curve, that is sputum prevalence, and increased dyspnea. He has been consistent with exacerbation of COPD along with increased chest tightness. These problems are mostly due to the viral or bacterial infection in a severe COPD patient. So for this assessment, what we have done, we know because of recent hospitalization, patient has higher risk of resistant pathogen attack. So a broad spectrum antibiotic is used, ciprofloxacin 750 milligram BID given oral, Samin for 14 days. Along with antibiotic, we also use corticosteroid medication, that is prednisolone, is included in plan to improve lung function and reduce hypoxemia. So in the case study, we get a condition that if oral ciprofloxacin 750 milligram BID increase the palpitations and nausea, what lab values should we check? So we assess that after changing medication, that is plan A, he has decreased symptoms of prevalence and dyspnea, but increased feeling of palpitation, sleep difficulty, and GI complaints, and other adverse effects may be due to theophylline concentration. So this is a dose-related adverse effect. What will we do? We will do a concentration test of theophylline. The result will be obtained and the further plan will be discussed. If we get a result of 21 mcg ml theophylline concentration, we assess that there is no life-threatening symptoms in this patient, but we can go with the conservative approach to withhold theophylline doses until the course of ciprofloxacin is completed. Because there is a low therapeutic effect of theophylline, later after 2 to 4 weeks level concentration, later after 2 to 4 weeks, we will again assess the concentration level of theophylline and start again. Now we have some basic notes in which we know that a COPD is a progressive disease. So stepwise treatment and patient counseling is very much needed to stop their steps get worse. So it is common for a severe COPD patient on multiple medications. Some of them may interact. So the assessment of adverse effect and patient counseling is necessary. So we may know which medicine we have to stop and which to exceed. Then we know that if a patient symptomatically have benefit, we will approach a step down technique in which we will reduce the dose or change towards a lower complicated medicines. So that's the whole presentation. Thank you.